Okay, let's unpack this. We've got a fascinating area to dive into today. Meniscal lesions.
hmm
This came as a listener request, specifically with MSRA revision in mind, the membership of the Royal College of Surgeons exam in orthopedics.
Right.
So if you're gearing up for that, consider this your streamlined guide to understanding a really crucial topic.
Exactly. Our goal here is, well, to distill the essential information about meniscal lesions. We'll cover what they are, how they happen, how they present clinically, and the key aspects of their management.
Yeah.
Think of it as your high-yield briefing,
Mhm.
perfectly tailored for your revision.
Fantastic. So let's get straight to it then. When we talk about a meniscal lesion, what exactly are we referring to?
Okay. At its heart, a meniscal lesion is simply damage or, tearing of one or both of the menisci.
Right.
These are the two C-shaped cartilage pads nestled within your knee joint. They're absolutely vital for a few key reasons.
Mm-hmm.
Primarily, they act as shock absorbers.
Like little cushions.
Precisely. Providing crucial cushioning between your thigh bone, the femur, and your shin bone, the tibia. They also play significant role in stabilizing the knee joint and even help with the smooth lubrication of the joint surfaces.
So they're like the knee's built-in suspension system, kind of.
Got it.
Got it. And I know there are different ways these can tear, right?
Exactly. Tears can be partial thickness or full thickness. And they can occur in different zones of either the medial meniscus that's on the inner side of your knee or the lateral meniscus on the outer side.
Okay.
But there's a particularly important type to be aware of for your revision: meniscal root tears.
Root tears, right.
These are radial tears that happen very close to where the meniscus anchors to the bone, or even a complete avulsion where it literally pulls away from the bone.
Wow.
Now, what's fascinating here is that a root tear can have a similar effect on the knee biomechanics as having the entire meniscus removed.
Really?
Yeah.
How so?
Well, think of the meniscus like maybe a tire-maintaining hoop stress. A radial root tear is like a significant cut in that structure, disrupting its ability to hold shape and distribute pressure effectively.
Ah, okay.
It's almost like removing the tire altogether in terms of how it changes the forces. This drastically alters the contact pressures within the joint. Not good for the cartilage long term.
Here's where it gets really interesting. So what are the common ways these meniscal lesions actually come about? What's the etiology?
Well, the causes are quite diverse, actually. A major one is sudden twisting or rotational movements of the knee, often when the foot is planted firmly on the ground.
Ah, the classic sports injury.
Exactly. Picture those quick pivots you see in sports like football or basketball. Then direct trauma to the knee, like a direct blow in contact sports, is another potential cause.
Makes sense.
Then we have the more gradual development of tears due to aging-related degenerative changes. The cartilage just, naturally loses some of its resilience over time.
Wear and tear.
Pretty much. And finally, repetitive stress on the knee. You might see this in certain occupations involving frequent squatting or kneeling, which can also contribute to meniscal damage over time.
So whether it's that awkward pivot during a football match or just the cumulative wear and tear over, years, there are several paths that can lead to a meniscal issue. Now, who's most susceptible? What are the risk factors we should know?
Yeah, good question. If we connect this to the bigger picture, you can really see how lifestyle and previous injuries significantly increase the likelihood of meniscal problems.
Okay.
Participation in high-impact sports is definitely a prominent risk factor, as are activities that involve a lot of that repetitive knee pivoting or twisting we mentioned.
Right.
If you have a history of a previous knee injury, like an ACL tear, for instance, you're unfortunately at a higher risk of subsequent meniscal tears.
Okay, that makes sense. Increased vulnerability.
Exactly. And as we touched on with etiology, those age-related degenerative changes make older individuals more vulnerable. And lastly, certain occupations or hobbies that place that repetitive stress on the knees can also elevate the risk.
Makes sense. So once the meniscus is injured, what's actually going on inside the knee? What's the pathophysiology?
So meniscal lesions, as we've discussed, involve these partial or complete tears. They can be medial or lateral, different sizes, different patterns.
Okay.
But regardless of the specifics, any tear disrupts that normally smooth, congruent surface of the meniscus, and that impairs its ability to effectively distribute load and stabilize the joint.
Right. The cushion is damaged.
Exactly. The most common mechanism, particularly in, say, younger, active individuals, is those forceful twisting or pivoting movements, often under load. But, and this is crucial, remember the difference in older individuals.
Ah, yes, the degenerative changes.
Precisely. Due to those changes, the meniscus is already less robust, so
Mhm.
even relatively minor forces, sometimes just getting up from a chair awkwardly, can be enough to cause a tear. And because the meniscus no longer provides that smooth cushioning and load distribution, you get increased stress concentration on the underlying articular cartilage.
Which leads to other problems down the line.
Potentially, yes. Over time, that increased stress can contribute to the development or progression of osteoarthritis.
Think of the meniscus like that cushion in the knee. If you twist it too hard or gets worn down, it can tear. And that's when the problems start, potentially leading to further issues.
Okay. Now, if someone comes in with knee pain, how do we differentiate a meniscal lesion from other possibilities? What's on the differential diagnosis list?
Yeah, this raises an important point. While our focus is the meniscus, knee pain can arise from various sources and often, multiple structures can be involved.
Right? It's complex.
So when considering a meniscal lesion, we absolutely must also think about ligament injuries. Things like tears of the anterior cruciate ligament, ACL, or posterior cruciate ligament.
Okay. Ligaments. Also collateral ligament injuries, the MCL or LCL. Then you've got osteoarthritis, which can cause similar pain, bursitis around the knee.
Inflammation.
Yes. And just other general intra-articular pathologies within the knee joint. It's also really worth noting that ACL injuries are frequently associated with meniscal tears, especially in younger patients with those acute twisting knee injuries. They often happen together.
Okay, so it's not always a straightforward diagnosis then. What about how common these injuries are? What does the epidemiology tell us, say, in the UK?
Meniscal lesions are indeed very common in orthopedic practice here in the UK. Very common.
Right.
They're frequently linked to sports and activities that subject the knee joint to significant stress. Interestingly, the reported incidence actually seems to be on the rise.
Oh, why is that?
Well, it's likely a combination of factors. Increased participation in sports across all ages, but also advancements in diagnostic imaging, particularly MRI.
We're just better at finding them now.
Exactly. MRI allows for much more accurate detection of these tears. The estimated annual incidence is around 60 cases per 100,000 people.
60 per 100,000.
Yeah, though many experts, myself included, suspect this figure might actually underestimate the true prevalence. There are probably more out there.
So if you're seeing a lot about knee injuries, especially in athletes, meniscal lesions are likely playing a big part in that picture. Got it. Now, what are the typical signs and symptoms? If a patient has a meniscal lesion, what might they experience? What clinical features should we look for?
Okay, the clinical presentation can vary quite a bit, but some common symptoms definitely include knee pain, swelling, and often a sensation of stiffness in the joint.
Pain, swelling, stiffness. Okay.
Patients might also describe a clicking, or more significantly, a locking sensation in their knee, particularly when attempting to fully extend or flex it. That locking is a key one.
Locking meaning they physically can't straighten it?
Yes, exactly, a mechanical block. They may also experience a limited range of motion, just generally, and have difficulty bearing weight on the affected leg.
Right.
Classic indicators often include reports of popping within the knee at the time of injury, a feeling of catching or giving way, episodes of the knee buckling unexpectedly.
Unstable feeling.
Yes. And localized pain right along the joint line. Often you can palpate this tenderness directly over the affected meniscus. But remember, the specific symptoms really depend on the tear's location, its size, and overall severity.
Right.
But the history the patient gives you, those specific complaints like popping, catching, and especially that true locking, can be very, very telling in pointing towards a mechanical block from a torn meniscus.
The history is key. So how do we actually determine what's going on inside the knee then? What investigations are typically used?
Well, our initial assessment always involves a thorough physical examination. We're looking for those signs suggestive of a meniscal injury, joint line tenderness, maybe specific provocative tests, assessing range of motion, looking for effusion, which is swelling.
The hands-on stuff.
Exactly. Combined with a detailed review of the patient's medical history, focusing on the onset and nature of their symptoms, any history of trauma. But when it comes to actually visualizing the meniscus directly,
Imaging.
imaging, yes. Magnetic resonance imaging, MRI, is the gold standard. It provides excellent detail of the soft tissues within the knee, including the menisci and ligaments.
Okay, MRI is key. What about X-rays?
Plain X-rays, while they don't really show the cartilage or meniscus itself, are still valuable. We use them to rule out other bony pathologies, like fractures or associated injuries like arthritis.
Right. Check the bones first.
And it's crucial here to remember the Ottawa knee rules. These are clinical decision rules that help us decide when an X-ray is actually indicated in acute knee injuries to avoid unnecessary radiation.
Yes, the Ottawa rules. Is there a mnemonic for that?
There is. A useful one to remember might be no flexion, no weight, fibula, patella, age 55.
Okay, say that again.
No flexion, inability to flex the knee to 90 degrees. No weight, inability to bear weight for 4 steps, both immediately and in the emergency department. Fibula tenderness at the head of the fibula. Patella isolated tenderness of the patella. And age 55 if the patient is 55 or older.
Got it. No flexion, no weight, fibula, patella, age 55. If any of those are present, consider an X-ray.
Exactly. Also, for acute knee swelling that comes on rapidly, say within 0 to 2 hours, you should consider offering an X-ray or even referral to A&E. Rapid swelling often suggests that hemarthrosis blood in the joint, which could mean a more serious injury, like a fracture or a significant ligament tear.
Okay. Good point about the timing of swelling.
And one more thing about MRI, it's worth noting that incidental meniscal findings are quite common. You can see tears on scans in people who don't actually have significant symptoms.
Symptomatic tears.
Precisely. So you have to correlate the imaging with the clinical picture. Finally, there's a more specialized technique, delayed gadolinium-enhanced MRI, which can be used sometimes to assess the health of the articular cartilage itself, not just the meniscus.
Right. Okay. So no flexion, no weight, fibula, patella, age 55. Great memory aid for those Ottawa rules. So we've identified a meniscal lesion. We've done our assessment, maybe got an MRI. What happens next? How is it managed?
Right. Management strategies really depend on quite a few things. The individual characteristics of the tear, its location, size, pattern, stability, but also the patient's activity level, their age, overall health, and whether there are any associated knee conditions like arthritis.
It's very personalized then.
Very much so. For milder tears, especially degenerative ones in less active individuals, conservative management is often the first line.
What does that involve?
It typically involves the principles of Pricer. That's protect, rest, ice, compression, elevation, and crucially, rehabilitation.
Pricer. Protect, rest, ice.
Compression, elevation, rehabilitation. Physiotherapy is key here, focusing on restoring strength, range of motion, and proprioception, the joint's sense of position.
Okay. And if that doesn't work, or for bigger tears?
Well, for more significant tears, especially acute ones in younger, active patients, or if conservative measures fail, then surgical options might be considered.
Surgery meaning?
Primarily, it could involve arthroscopic meniscal repair, stitching the torn edges together. This is usually attempted if the tear is in a location with good blood supply, the so-called red zone, offering better healing potential.
Repair if possible.
Ideally, yes, to preserve the meniscus. The other main option is a partial meniscectomy. This involves surgically removing only the damaged, unstable portion of the meniscus, leaving the healthy tissue behind.
Trimming it out.
Essentially, yes. Smoothing the edge. Now, it's critical to remember a suspected meniscal injury that presents with true knee locking, where the knee cannot be fully extended.
The mechanical block we mentioned.
Exactly. That warrants urgent referral to an orthopedic specialist. Prompt assessment is needed, as it might require urgent surgical intervention to unlock the knee.
Urgent referral for locking. Got it.
And physiotherapy, as I said, plays a crucial role, not just conservatively, but also in rehab after surgery. While that arthroscopic partial meniscectomy is common, non-operative management is often the initial approach, especially for degenerative tears in older individuals where surgery might not offer significant benefit over physio.
Right.
There are also more advanced surgical options, though less common. Things like meniscal allograft transplantation using a donor meniscus perhaps for younger patients with significant post-meniscectomy pain. And even novel treatments like partial meniscus replacement using biodegradable scaffolds are being researched.
Fascinating. So lots of options.
Definitely. The management approach really underscores the variability. A small, stable degenerative tear in an older, less active person might be managed very differently from a large, complex repairable tear in a young athlete.
That makes total sense. Tailoring the treatment. So what's the expected outcome then? Prognosis. And are there potential complications we need to be aware of?
Yeah, the prognosis after a meniscal lesion really depends on that multitude of factors we discussed. The tear type, location, size, the patient's age, activity level, any associated arthritis, how it was managed.
Okay.
But in the majority of cases, with appropriate management, whether that's conservative or surgical patients, do experience significant relief of their symptoms, like pain and locking, and a notable improvement in their functional abilities. They get back to doing more.
That's good news generally.
It is.
Oh.
However, potential complications can arise. These might include persistent pain despite treatment, ongoing limitations in knee function, and importantly, an increased risk of developing or accelerating osteoarthritis in the affected knee over the long term.
Because the shock absorption is compromised.
Exactly, the altered joint mechanics. And sometimes further surgical interventions might be needed down the line. So, early and accurate diagnosis, followed by timely and appropriate treatment, are really important for optimizing those long-term outcomes.
Makes sense.
And just one final point on management and outcome. The rehabilitation protocols can differ quite substantially depending on whether a patient had a meniscectomy versus a meniscal repair.
How so?
Well, after a partial meniscectomy, rehab is often quicker as you're just recovering from the arthroscopy itself. But after a repair, you need a more cautious, protected approach, often involving bracing and restricted weight bearing for a period to allow the meniscus itself to heal. It takes longer.
Right, protecting the repair.
Exactly. So while many people recover well, it's definitely a reminder that looking after your knees and seeking timely help for injuries is crucial for long-term joint health.
Absolutely crucial. So just to quickly summarize our deep dive into meniscal lesions for everyone revising, we've covered the definition, what they are, those C-shaped cartilages, the various causes or etiology from sports twists to degeneration, who's most at risk, the risk factors, the underlying pathophysiology, how the tears affect knee function, what other conditions we need to consider in the differential diagnosis, like ligament tears or arthritis, how common they are, the epidemiology, about 60 per 100,000, but maybe more. The typical clinical features patients present with pain, swelling, locking, catching.
Yeah, those key symptoms.
The key investigations, especially MRI as the gold standard, and when to use x-rays using the Ottawa rules, no flexion, no weight, fibula, patella, age 55.
Good recap on the mnemonic.
The range of management options, from conservative Pricer and physio to surgical repair or partial meniscectomy, remembering urgent referral for locking, and finally, the likely prognosis and potential complications like future arthritis. Hopefully, this has provided a really solid, high-yield overview for your MSRA revision.
Absolutely. Hopefully this has given you a clear framework for understanding meniscal lesions and really highlighted the key aspects you need to focus on for your exam preparation.
Fantastic. And just a reminder, for more in-depth resources to assist with your MSRA revision, be sure to visit pastthemsra.com.
That's right.
And you can also find a wealth of free MSRA revision materials available over at freemsra.com.
Great resources there, too.
Thanks so much for diving deep with us into this important topic today.
My pleasure. And maybe just a final thought to leave you with. Consider this. With increasing participation in high-impact sports across all ages and an aging population more prone to degenerative tears, how might our approaches to both preventing and managing meniscal injuries need to evolve in the future? Something to think about.